Good morning, folks. This is John Adamson, the Rehab and Documentation Guru. So, I'm going to read for you an email that I got from a viewer and somebody that took my documentation course in the past. And I will share that this individual works in a home health setting, but I won't share their discipline. So, they start off with just kind of a greeting, and then they go on to this. I am feeling challenged with the way management seems to be interpreting the payment model and the request requirements of therapy. So we're talking about PDGM. The most recent concern is that they want visits for all patients to be tapered. I'm working with a blank, a therapist, so this is an assistant, that was told they needed to start tapering visits. They typically they typically plan treatment for 2 times a week, which doesn't leave room to taper much. They were instructed by the clinical manager, who is an RN, that they need to start with 3 times for 1 week, then taper down so that it is showing tapered visits. Before this, the therapists were told they could not plan 3 times a week because management felt it was overutilization of visits, and PT and OT were not to both plan 3 times a week without management approval. This all started about a year before the new model became effective so that it would not look like the change was in response to PDGM. I wanted to get an outside opinion from someone who is not personally involved. So, first of all, thank you for reaching out to me. And I think this is a situation that as many of you have heard me talk about in the past, and my answer will probably sound very familiar because the general guidelines I've talked about in the past certainly apply here. So, first of all, in my course, I talk about tapering dosage. And unless you're in an acute setting, an acute rehab setting, or a SNF Part A setting, where the goal is to get the patient as safely and effectively and as quickly off your service as possible to reduce Medicare Part A days. All other settings, including home health Part A, probably should be tapering their dose. One of the things you're trying to prove is you are weaning the patient off dependency upon you to where they can become their own health advocate and take care of their own health issues. So tapering is probably a good situation for all patients, but should it be mandated? And I'm going to get to that in a minute. And then this therapist goes into the fact that they were told by a clinical manager to treat 2 times a week, and that you could start 3 times a week, but then you should be tapering right away, and that PT and OT shouldn't be both seeing the patient 3 times a week. Well, this again goes back to patient specificity. You cannot, from a third person, removed from the patient care directly, make that determination. So the therapist and the patient are making that decision. The therapist who has one-on-one perspective with that patient in a way that even the best documentation is not going to capture that same perspective, honestly, has to be the one that determines the frequency that's best for the patient. And there are patients that their acuity level is so high, their needs are so great that they need PT and OT 3 times a week. It's just going to be indicative of their problem list, the things that are going on with the patient. There's no way that you can dictate from afar. And really, when you're just somebody that's not directly involved with the patient, you are dictating from afar. There's no way that they can honestly say these patients must have this level of care. So that's got to be up to the individual therapist. But I would agree with the management in this case that it should be tapering. We should be having a tapering dose as we get ready for discharge. Now, I am a little bit concerned about this statement. This all started about a year before the new model became effective, so it would not look like the change was in response to PDGM. Now, if that's true, And I don't doubt the veracity of this person that's emailed me, and I would really appreciate her reaching out to me. But if that is true, that they wanted to have the appearance of it not being in response to PDGM, that is concerning. And I know that this is not an isolated instance if this is the case. Um, the payment model, again, is a payment model change. It is not meant to be a change in how we approach patient care. And so if you're just trying to look like you're doing the right thing, that's a problem. We should be doing the right thing regardless of whether somebody's looking or not. And that, my friends, is called integrity. Anyway, folks, thank you so much for listening. Please like and subscribe. And thank you, this person who wrote me, for giving me a good subject matter to cover today. Take care, God bless, and have a great day.